Dr. Janet Wright, who is going to be moderating our next session to introduce our amazing panelists.
Thank you so much, Jenny, and thank you so much, Dr. Winger, for setting our course today. I am honored to join this wonderful panel. You see the photos and their titles. I will tell you some backstory. I will tell you that Karol Watson has been a North Star for me. Her work has been a North Star for me for many years. And she is in a place that can help and continue to lead us using the evidence and the science to innovate and to bring partners together. Dr. Presley-Cantrell is now a colleague of mine. She oversees the state funding, state and local health department funding for our Division for Heart Disease and Stroke Prevention, been focused on equity and including gender equity for decades, and it is my honor to work with her officially now. And then Marcia Kritzler-Egeland is a new colleague of mine, a woman who has been a teacher for many years, who has experienced heart disease firsthand, including hypertension, and is now an expert, a champion of through WomenHeart, a very powerful organization that has led for years in helping women understand their risks and address their risks. So it is an honor to bring everyone together today, especially on the heels of such a brilliant presentation by our fearless leader, Dr. Winger. So I think what we'll do is we'll start in a round, and I'm not seeing Karol. I know that Karol had an emergency today, so we'll leave the lines open. And Moderator, I wonder if you'd be willing to join us, perhaps in Karen's absence or until she's able to join us again.
Happy to.
Wonderful. Thank you so much. So my three brilliant panelists, I'd like to start with a round of questions about why you care about hypertension in women and why anyone else should care about it. And Marcia, if you don't mind, we'll just kick it off with you. Oh, mute.
You're muted, Marcia.
We want to hear every word.
There, how's that?
Perfect.
Okay, so I have been suffering with high blood pressure, hypertension for a little over 30 years. So it's a personal thing. There's a family history, but because I've always been an educator, I found myself after I retired due to my heart attack that I needed to do something, and I found WomenHeart, or they found me, and I've been advocating ever since. It's so important. We are underserved. And if I had received the counsel that I needed and I deserved, like every other woman, possibly I would not have had 2 heart attacks in one day 8 years ago. I would not have had bypass surgery. And I could have functioned better in my life. And I want to make sure that other women are educated, they know how to advocate for themselves, and they get the advice and the support that they need.
Thanks. Oops. I can't tell if I'm muted or not. Can you hear me? Yep.
Yeah.
So Marcia, I hear mission. I hear mission first. Yes. I hear you wrapping yourself up in that mission, and we are grateful for it. So I will turn to you, Letitia, because I know you are on a mission as well. Speak to that. Share that.
So like Marcia, I had some similar background, but I had a pregnancy-related hypertension issue and had some issues right after delivery of my son, and was told that I really needed to tap my type A personality down, that I was too aggressive and ambitious, and that was the reason I was having these issues, with this delivery. But I come from a family history of high blood pressure and stroke. And so I knew I needed to do something, but the medical system just didn't cooperate with me. And then when I came to CDC after I left Morehouse School of Medicine, I recognized something was wrong. I mean, when I first came out of school, I was a respiratory therapist doing neonatal transport. And so what was happening was most of the babies that I were taking care of were from African-American women. And I was starting to see some connections, but just really couldn't make the full connection for what I was seeing on the ground. And so upon arriving at CDC with this abundance of data, making even more discoveries, but not really understanding what's going on. And even at the agency at the time, talking about social determinants, talking about racial inequalities were not things that we were allowed to really discuss. And so it became a lot of backdoor conversations with a lot of other folks who were sensing something was wrong, but just couldn't put our fingers on it. And so for those of us that are now able to talk about these things out loud and in person, some of us have been kind of working behind the scenes for years, trying to bring some of this to the fore. And so now that we're able to really talk about these systemic ills and what we need to do, it is, just part of what I can continue to do at the agency to bring these issues to the fore to make sure they get discussed. One of the things that we don't focus on enough is women's health, and it's been a passion of mine. You have a mother that has had 2 heart attacks, unconventional symptoms, a sister that has high blood pressure, a grandmother who lived to be 93, was the smartest woman I ever knew with a 3rd grade education, but she succumbed to her 3rd stroke at 93. And I know some of you are saying, well, it's 93, but I think she could have lived to be 110 had she not had the last stroke. But we don't talk about those things. And we also don't talk about the psychosocial stress of women, and particularly minority women, as they go through their lifespan, and what living in a race-conscious society does to women, and especially when we have policies that create circumstances for certain groups of women and people, and particularly women. And we need to really think about the intersectionality of all of these things. So that's just where I'm coming from. I know it's not been popular here sometimes, but it is what it is.
So, and Letitia, what I hear you say is these backdoor conversations need to move even well beyond the front porch to Main Street and to the halls of Congress. For everywhere we can speak, we need to make sure these messages are heard. Karol, we're delighted that you're joining us. I expected to see you in scrubs if I saw you at all, but we're making a round about why we care about this, or why anyone else should care about women in hypertension.
Yeah. So from a very selfish and personal place, I come from a family that's been devastated by strokes and heart attacks. And hypertension is such a driver of so much of the disease in our community, and we know this. And unfortunately, everyone knows hypertension is bad, but everyone sort of brushes it off. Oh, don't worry, my blood pressure is always high. Oh, that's just our family. It's fine. And we don't see what the other side of that looks like. And it's not pretty. Right. So we really have to get that across. But the other thing is exactly what Letitia was saying. There's so many structural barriers that people have to confront. Obviously, African Americans have a much higher incidence of hypertension. It's not our race, but it is the social determinants that impact our race. It's racism, it's poverty, it's lack of income and education and all of those things. And some of our policy decisions don't make it easy. I mean, we tell people you should have 5 servings of fruits and vegetables per day. Do you know how expensive grapes are now? I mean, come on. And those are the things that go bad in our refrigerator. And when you're living on a limited income, you make every penny count. So that banana that rots on the counter is a meal you don't get one day. And it has to be easier to do the things, to get the time off to go to your doctor's appointment, to have your medication that's life-saving covered completely, maybe even without a copay, because it's a life-saving medication. We have to make it cheap, easy to do the things that make people do better. It's going to impact all of us positively, not just each individual, but society as a whole.
Karol, I think you've set us up, all of us, brilliantly for sort of the next round of questions, which is, we know why we're in this. What are we doing? And maybe I'll just go back to you, Marcia. You want to talk about WomenHeart and how WomenHeart is contributing?
Yes. I've been advocating WomenHeart for the last 6 years. I personally am trained to facilitate a support group for women. I have women in my group who are here locally in Little Sturgeon Bay, Wisconsin. And I have others who join me virtually from other parts of the country where there are no WomenHeart support groups. We educate, we provide advice, obviously not medical advice, but it's a place where women can come and get the support, some of the support that they need. If you go to the WomenHeart website, womenheart.org, there is a lot of information. We have programs like Sister Match, which I used prior to my bypass surgery. And I was connected with another woman in another state who had had bypass surgery. And she answered my questions, how was she emotionally? She just made me feel so much better. And she was very concerned about my welfare. She called me after my surgery to make sure I was doing okay. How was I feeling? So it's a wonderful organization, and it is the only organization whose sole purpose is to support women living with heart disease or who are at risk of heart disease. And for me personally, it's very gratifying. And I just want to reach more women.
Marcia, it strikes me, one thing I heard loud and clear from Dr. Winger was to meet women where they are, to
Yes.
come to women. And it's not surprising that WomenHeart is designed that way, since I believe Dr. Winger was a design architect for WomenHeart and certainly our continuing inspiration. So that might be a good place to go to Letitia. Letitia, nobody more than you believes in going into community. So speak about what levers you hold to help women in community.
Well, one of the things we have to remember is that I work for a public health agency, and so public health is the entire thing, right? It's the totality of it, and healthcare systems are one piece of public health, but we are interested in the entirety of what's going on in the continuum of care. One of the things that we've learned through our programs, and we're continuing to modify our work and to really listen to what we're hearing from women on the ground, is that we have to be where they are. But we also know that we put these scientific pieces into place, and a lot of folks have talked about build it and they will come. Well, they might come, but will they stay? And so what we've been trying to figure out in our public health lane is, how do we actually engage women to get them not only into care, but to stay into care for the long term? And part of what I've been doing with our data and our women's program is just looking at the dose of the intervention. How much of the intervention is required for us to see some effect? And then how long do we actually keep women into care? And so we divided this into what we call steps. And what we notice is that we can get women into care at step 1. By steps 2 or 3, they're gone, but we need them to at least be to step 3 to get the full dose of what we're giving through the lifestyle intervention, to help them actually maintain good practices and to improve their care. But what we also learned is that we did not look at all of the factors that were going on in these women's lives that would either enable them to participate in a program. And so a lot of them just said to us, I can't come, I can't get off work, I can't come, I don't have transportation. A lot of it wasn't even about money and transportation for some of our women. They just went there mentally, right? It was too much of a stress going on in their lived experience for them to even participate. And so what we started to do is to intervene at all levels now. So what we recognize is that this mental health component and this psychosocial stress around this lived experience for women is much to what Dr. Wingo talked about earlier, that there are a lot of stressors that women have in their lives. They are family caregivers, they're their caregivers. I mean, there are a lot of policies. Karol mentioned that. What about the policies that are in place for minority women? And for us, African-American women are now a priority given the rates that we see. But we also know that there have been public policies that have been in place that have put African-American in a position to be breadwinners in their families. So they have that economic stress along with all of the other stressors. And so what we've decided is that I need to get you into care and I need you to stay. How do we mediate those stressors? So offering free mental health services, support groups to women that come into care, daycare. We have our Hispanic and Latino populations. We have the grandmothers come in to keep kids. We offer healthy snacks. Back to what Karol said, it's expensive to buy fruit. I myself am on a great diet right now. So these are the things that we have to think about in terms of long-term care and maintenance. And even with working with these women, how do we get women to recognize that self-care is healthcare? There's so much going on that we keep focusing on. Come to the doctor's office, we're going to give you some medication, but these psychosocial stressors that we have to mitigate to keep women involved in their care, to recognize the importance of that care, are becoming more pressing for us. So as a public health steward, we are now redirecting our programs to focus on a lot of those community pieces that have to be in place, because you're only at the physician's office or the provider's office 10 or 15 minutes. You go home for the rest of your life, and we've got to figure out that part of the equation.
Yeah, well said, Letitia. And we may come back to the idea of all of these stresses that you've been mentioning. We know figures into maternal mortality and morbidity, cardiovascular disease being a #1 contributor to those awful outcomes. So Karol, speak to us about your work.
Yeah, so it's like Letitia and I planned this. So we do a number of different things. In our Women's Cardiovascular Center, we have been focused on the heart-mind connection for a long time, because I can't pretend that I can help your heart if I cannot know what's going on in your life, the stressors, the stress, anxiety, and depression. So we've actually gotten a wonderful, beautiful grant to support a cardiac psychologist that's embedded in our Women's Cardiovascular Center, and every one of our patients can see her for free. So we do interventions aimed at reducing stress, anxiety, depression, and that is so vital. I can't tell you how much of heart disease is adversely impacted by those three things. That's what we do for our patients who are already into our clinic. For our patients who are not, or people who are out there who don't even realize they may be at risk, we do a lot of outreach programs. We do a yearly program called Let's Talk about women and heart disease. We do a program called Research That Matters, where we present some of our research finding. And we do some boutique programs, like something called A Taste of Health. We partner with a chef, and we actually do cooking classes, thinking about ways to healthify your recipes. So that's what we do for women who we're trying to reach into. And we try to go to communities of color and underrepresented communities so we can get the word out. The final thing we do is try to reach the younger people. So we sponsor a UCLA teen heart health program that was actually envisioned and conceived of by 3 teens. So it's where teens talk to each other to get the message out. So we realized a long time ago that my high school kids aren't listening to me, but they will listen to college kids. And, middle school kids aren't listening to mom, but they will listen to high school kids and things like that. So teens getting the word out to other teens.
Well, talk about coordination, because my next question, which I didn't warn you guys about because it came from Dr. Winger's comments, is this concept of the life course approach and starting early. And it applies to women and men, of course, but I'd love to hear what your thoughts are and what you already have working towards creating that healthy trajectory from childhood through all stages of a woman's life. Marcia, I know that's kind of a hot potato, but let me toss it at you.
Well, thank you. So I think it's a wonderful concept. For instance, for me as a hypertension patient, a heart patient, women living with type 2 diabetes. I mean, I grew up in a household that we had excellent meals, very healthy meals. My mom was really ahead of the curve. But if there had been more of a lifestyle approach to my health care as I was growing up, in terms of even, going to school, middle school, junior high, high school, it would have possibly changed things. And I think it's imperative that we have this type of education commitment throughout our lives. It's, if I had gotten more advice the first time I saw a cardiologist when I was 41, 42 years old, it might have changed things. Instead of saying, oh, she's a very nice lady, and not explaining to me what the calcifications were that they saw in that first catheterization, that instead of saying, well, you're a woman and you're protected, so don't worry about it. So I wasn't worried about it. So it needs to happen in all facets of our life. And that's one of the things that I think is very helpful with WomenHeart, through the population of women that I see. And I hope I'm not taking up too much time here, but
no, you're
when I put together I spend a lot of time putting my meetings together. That time with my group is valuable. And so I've been able to bring in medical professionals, dietitians. Next month we're having a cardiology pharmacist come to our meeting, and I want to make sure that my ladies get all the information that they need, or as much as I can possibly provide.
Yeah, it's personalized for their needs because it's in a community setting. Quite a mechanism of support. I think I need to just say to our audience that I'm going to open the floor in a moment for questions that you all might have of the panel, but please be I see comments coming into the chat with questions. So let me ask you, Letitia and Karol, if anything you'd like to say about that life course approach before we open the floor for questions.
I mean, I'm all for life course. I mean, one of the things that I've done at the agency, and it's probably the biggest secret, is I started an internship program for minority serving institutions, for HBCUs, for Hispanic serving institutions, and for tribal colleges and universities. And one of the reasons behind that is because when we were looking at workforce data early on in early 2000, we realized we didn't have enough of persons coming from these communities in public health and needed to find a way to try to retain them. And so we went to those minority serving institutions. But up the road a little bit, looking at what we were seeing in terms of the health issues that these students were facing, it became obvious that cardiovascular disease was something we needed to focus on, and particularly hypertension. So I've started in those schools talking circles for women, for young women, to understand that having a parent or a grandparent that has hypertension doesn't mean that you're in the clear, and that you need to start having better practices. Now that's kind of hard to tell people who are eating fried Oreos, as I was told, and dipping them in Kool-Aid and frying them. Some of these things I'd never heard of, but I was glad to learn of them. But it helps me to understand that we really need to start talking about lifestyle and diet at earlier ages with our kids. And just because we model these behaviors at home does not mean our children, when they go out into the world, actually engage in those behaviors. So as a parent of 5, I've seen that firsthand. But I did recognize that if we could start to talk about health, and particularly hypertension, on these college campuses where it was becoming more and more prevalent, that we might be able to do something a little earlier than waiting until these folks kind of age into it, unfortunately, and have these conditions. So we started a program looking at how to talk about hypertension. What does it look like in your community? How do you talk to your peers on these college campuses about this? And the thing that I can say is this an easy task? Absolutely not. But it is one that we have to engage in these communities, because this is where we are seeing the highest rates. And so the students actually have enjoyed the cooking sessions, as many of them don't understand how to make decent meals, but also recognize that there were other components, such as the drinking and other things that they were doing, that we were having to discuss with them in terms of heart health and living healthier lives. Now, again, that's a hard task for young folks who are living their best life right now, but I wanted to at least plant these seeds in the hopes that as they move upward, that they would be able to remember these things and at least lean back to them as they begin to live better lives.
I think you can tell from one of the things we support, the Teen Heart Health Program, that we believe in the life course. And one of our taglines is, so much easier to lay down good health habits young than to break bad habits when you're older.
Well said. Well said. So I'm scrolling through the chat box, and I see a couple of questions here from Hattie Reese-Hanley, leader of the Right Care Initiative.
Hey, Hattie.
So Hattie, would you like to come off mic and just ask?
Well, thank you, Janet, and lovely to hear all of these wonderful patient experiences and just a positive approach that can make it practical to drive down women's cardiovascular disease. Certainly what we've found using the CDC Wonder data, that thank you, Janet, for making that available, because it's shocking. And it's women don't know that already by the age of 35 to 44, heart attacks, strokes, and hypertension emergencies are killing more women than breast cancer and and cervical cancer combined. These are things that we're screening for on a regular basis. So there are so many questions to ask each of you, but Marcia, I was absolutely fascinated by your talking about not being notified that you had calcifications in your heart. Could you elaborate on that, please?
Sure. When I had that first intervention, I was not anesthetized in any way. I was awake, and so when that dye went through my system, I thought my head was going to blow off, and then I said to the technician, well, what's that stuff in my heart? And he said, oh, it's calcification. It's some calcium up there, but, and then when I did see the doctor, I asked about it, and he basically treated me like, oh, little lady, you don't have to worry. You haven't reached menopause yet. You're not, you're protected because of your hormones. And so, I then, all these years later, I found out that, I had heart disease. No one said to me, this is what it is. this is what you should be doing. And, you know, I always exercise. I eat a healthy diet. And my children did too. So, you know, in retrospect, it was like, I didn't know I should be educating myself. I thought that the medical professionals were there to educate me. And that's not the way it was working then. And it's not always working that way now. So, you know, anything that we can do to change the system, and anything that we can do as patients to advocate for ourselves, to educate ourselves. We have to, because no one else is doing it for us.
Thanks, Marcia.
Thank you. And
Go ahead, Hattie.
I'd love to follow up with you, Marcia, about coronary calcium. I'm all over it. 1 in 9 women, according to the Cardiology study, already have that coronary calcium by age 45. And that's got to be part of the picture of why young women are dying. It's just part of the picture. Hypertension, critical. And Karol has been such a hero in our Southern California Wright Care group. Prior to COVID, I haven't seen her much since COVID, but thank God for Zoom that we can all get to know each other across the country now. But Karol, I loved hearing about your mind-heart connection, and also about the concept, I've never heard this before, of healthifying meals. We should be all over that. So I just would love to hear more about those exciting things you're doing.
Thank you for that. We didn't make up the word healthifying. Somebody else did. But that's what we do with our stuff. So things like sneaking in vegetables, swapping olive oil for saturated fats, using vegetables as a major part of your meal. One of the first things our chef taught us, she said, why can't vegetables be the most yummy thing on your table? And we all rolled our eyes and looked at her. And then we spent a cooking class with her, chopping up vegetables, slathering olive oil on them, sprinkling a little salt, and slow roasting them for 2 hours. And I tell you, those are the yummiest things I've ever tasted. They are the yummiest things on the table, and even my kids agree. So yeah, there's a lot of little things you can do. And it's obviously, we understand that some things we're eating are not going to be particularly healthful. But I always say, if you know that what you're eating is not going to make you healthier, make sure it makes you really, really happy, and just eat a little bit. But I think a lot of things that we eat can be made healthier, and that just teaching people easy tricks to do it is nice.
Janet,
Thanks so
Dr.
much.
Wing.
I see. Dr. Winger, your hand is up. Please, microphone's all yours.
Yes, Dr. Ogunyi will know with me that at Grady Memorial Hospital, we have a program called Food as Medicine, and patients get a prescription. We have a mini market in the parking deck, and for patients who live in food deserts, they can buy or they can get on prescription inexpensive foods. There are cooking classes that are run there, and it's just amazing how many patients will partake of that. And we've really used this as a model. And I think anyone who's interested in doing it at their facility, I'm sure that the people at Grady Memorial Hospital will share that concept with them, because I expect that the whole idea of food as medicine is something that should grow.
Thank you so much for that. And I see, Modele, you put the link in the chat. Thank you. I will add to that the idea that physical activity is a vital sign. Some places around the country are collecting the minutes of activity along with blood pressure readings, et cetera, to just send a strong signal about the importance of that. I wonder, with a few remaining minutes, I'm going to warn our panelists, I'm going to ask you to issue a charge to the rest of us who are here to listen before we close. But maybe I'm going to put one more question on the table. Dr. Winger shared with us a lot of very troubling data about hypertension during pregnancy and the impact on that on the rest of someone's life. And I wonder, Dr. Winger, you mentioned a postpartum, a preeclampsia clinic, which at least for me was a way to solidify that handoff between clinical teams that have cared for someone during a pregnancy and then the handoff thereafter. I don't know that every place in the country can have a preeclampsia clinic or handoff, but I'd like to ask our speakers, how do you envision better connecting teams, both those in the clinical setting and those that are in a community, to make sure that a woman who has hypertension during pregnancy has no lapse in care and in attention to blood pressure?
Well, we've a couple of years ago started a cardio obstetrics program at UCLA, which has been just phenomenal. So obviously, patients who get pregnant with severe heart disease, congenital heart disease, acquired heart disease, they obviously get taken care of. But the beautiful part of it is patients who have pregnancy related hypertension, diabetes, anything else, they get handed off, a personal handoff. We see them and follow them long term. That has been the most amazing thing we've had. And honestly, Yalda Afshar is a high risk maternal fetal medicine physician who started the program. And really, it's the strength of her personality. And she took us all by the hand and said, come on, you're coming along. And we all did, and we all love it. So having a champion like that to do something like this is key. And now it's seamless. There's a referral made instantly. If you have abnormal cardiovascular parameters, you get seen.
Yeah, and I would follow up with what Karol was saying. I mean, one of the things that we know that Dr. Winger mentioned too is that getting women healthier before they even have a pregnancy. So in our work in terms of public health, our entire goal is to mitigate things like weathering. Geronimus puts a concept out about weathering and this high effort coping and stress and how to mitigate some of these factors. So we want to look at decreasing things that are associated with these types of risks, getting women in the best position possible so that if they decide to have a child, not all women do engage in pregnancy, but if they do decide to have a child, we want you to be in the best possible health to come into that pregnancy to ensure that you have even better outcomes than before. But a lot of that, again, is on the prevention side and mitigating some of the stress that leads to obesity and some of the other risk factors in women that we are seeing. So from a public health standpoint, we're becoming more full circle in understanding how women get into these conditions, and so to speak, and mitigating those risk factors before they become to that level. So that's just, it's not a small thing, but it's something we recognize in public health that we really are going to have to pay more attention to.
And as for me, what you both have said is wonderful. To be prepared before you become pregnant, to live a healthy lifestyle, and to have that support before, during, after, and to know that if there is an issue, you're going to be handed off to somebody who can help you and continue giving you the medical support that you need. I was having babies almost 50 years ago, and fortunately, I did not have those particular gestational issues, but I had friends who did. And now, one of those women happens to be in my support group, and she has so many health issues now that maybe can be traced back to that issue of that she had during her pregnancy. So thank you for doing what you're doing.
Well, you guys have dropped a lot of pearls. I'm going to ask you in a 1-minute lightning round here. If you ruled the world, Letitia, and you could have folks do one thing, roundtable members and those who've joined us today, what would you ask to help improve hypertension control in women? Or you can take it in any direction you want, but the topic is hypertension in women.
I don't know, Janet, that was too much right there. I think the first thing I would do would tap away all the isms, because a lot of this is around structural things that we're encountering and policies that are in place that don't actually allow people to fully engage in our healthcare system for whatever reason, whether it is around insurance, payers, or social determinants. So if I could tap away all the isms, it would probably actually give us a better shot at equity. And I think if we had more equity and parity across some of this work, that would improve everybody's outcomes, and definitely those that are unfortunately disproportionately affected.
I see you sword in hand, getting rid of the barriers, getting rid of the barriers. So thank you for that.
That's all right.
Carol, I'm going clockwise here on my screen.
So again, this is my magic wand, my wish list. I would make every life-saving medication free of charge with no copay. So if it's ever been proved in a randomized controlled trial to reduce heart attack, stroke, cardiovascular death, it's free. Insulin, it's free. All the things that are life-saving, absolutely, they're free.
I'm taking notes here. I love it. We got a sword and a magic wand. Marcia, you're going to bring us home.
Okay, and for me, it goes to education, that everybody gets the health care education that they need, the lifestyle education that they need, so that they can make wise decisions when it comes to what they put in their bodies, how they take care of themselves, to make movement part of their daily routine. That also goes back to equity, that everybody gets this.
Awesome. You know, what I hear is we need the conditions for health, and we need to make sure we understand what the healthy choices are. And then, as you said, Carol, take away those things that are in the way of getting people treatment if they need it. Dr. Winger, please.
Yes, you know, when I've spoken to WomenHeart over the years, I said that there are 4 steps for women's heart health. The first is investigate, get the data. The second is educate women and their providers. Next is advocate, and last is legislate, because that's where it has to be. So it's investigate, educate, advocate, and legislate. And that's where we should be going. And that's everything that I have heard today from the wonderful, wonderful participants.
Thank you so much. Wise words to end on. Let me thank the panelists, as well as our Moderator for dropping in for coverage, and Dr. Winger for continuing to grace us with your presence and expertise. Thanks, everyone.
May I also say thank you to Dr. Winger for all the mentorship and advocacy that she's given all of us all these years. Thank you, my friend.
Indeed. Jenny, I will turn things back over to you.
Thank you, Janet. And I want to echo thank you to all the panelists. And I